Should we flank the podium, I guess?
So I'll just intro you guys, and then you guys can intro our speakers.
I'll do Jesse, and then...
Yep.
I'll get them up here before I say goodbye.
Yeah, let's do that.
Did you... I sent slides last night.
Yeah, Mona was telling me this morning, she went back. Were they different? And she's like, I checked them, she pulled them up against the ones that they already had.
I made
she
some...
said they look exactly the same.
I just...
But she swapped them regardless.
She swapped. Oh, that's good. They're more or less the same, some tweaks. I just want to make sure it was a PowerPoint, not a PDF that you sent, because there's animation in it.
You know, I'm
okay. Either way, it's... I'll work with whatever it's trying to do.
I think it's going to be...
She told me this morning she swapped it out.
Then that's all I need to hear.
She asked if she had the right file, because to her eye it looked the same. So...
did I send... Maybe I could have sent the wrong one. We'll see. If I did, I'll wing it. And it's not a
well, if there's a way... Was the title something that I... would tell me if it's the right one or not?
No, don't worry about it.
Okay.
Minor.
All right. Good. Hey, good morning. Good morning, all. I hope you're enjoying your breakfast. Welcome to day 3 of our People-Driven Transplant Metrics Conference. I was tired last night. I don't know about you. I think we had a great day. It was a robust discussion. I enjoyed the breakouts. I hope you did as well. We have a great morning. I won't say too much other than today is the day we really want to get into more specifics about how we can actually achieve some of the recommendations that we've heard throughout yesterday. So we spent some time with our moderators last evening creating a concise list of what we've heard thus far, and that will be the focus of our breakout groups this morning. So look forward to that. But first we wanted to kick this off with a great panel discussion here of experts in this field. And so I'll just begin by introducing our moderators for the session. Dr. Sumeet Mohan is Associate Professor of Medicine and Epidemiology at Columbia University. You've all seen him a number of times. And to my left, Darren Stewart, Principal Research Scientist at UNOS in Richmond, Virginia. So good friend and colleague. So I'll turn it over to them for our session this morning.
Thanks. Good morning, everyone. John, we're not going to lie. Yesterday was pretty grueling. It was good, but grueling. I hope everybody was able to kick back, relax a bit, get a drink, and do whatever last night to kind of take a load off, because we're going to work again today. It's a half day, but we've got a lot to accomplish. I'm going to introduce Jesse Schold, who really needs no introduction. He's really become a household name in the transplant field. Jesse's from Cleveland Clinic. He's done a tremendous amount of work in the transplant research broadly, but in particular in terms of metrics. And he's been a thought leader, at times a provocative thought leader, but in a good way, to really help ensure that metrics are helpful and not harmful, and considering potential unintended consequences. And so he's certainly the right person to have here and stimulate thinking about the direction that we should go with potentially more metrics. So without further ado, Jesse.
Thank you, Darren. That was a horrible picture. I don't know, you guys had something against me when you put that up there. It's really been it's a pleasure to be here. I really want to congratulate John and the whole SRTR team in putting on a fabulous meeting, and it's to have an excuse to have all this engagement and interaction is great among all the thought leaders and combination of stakeholders, and in particular patients. As a researcher and as a segue to my talk, I spend a lot of time in front of a computer and with data, but very limited time interacting with patients and the ultimate stakeholders that matter the most. And so it's been very invigorating for me. I've learned a lot, and I really appreciate the opportunity to be here. So as given by my task as a researcher's perspective, I've been doing research, as the gray hair and the lack of mustache shows, for more than 20 years or so, and most of it in transplant. And I suspect the rest of my career will be in that, assuming the Red Sox don't call me as I had hoped. And part of that is because it is such a rich and invigorating field for research. There are so many questions, so many opportunities, so many different perspectives in which can inform research. And what's most satisfying is seeing that your research integrated into practice and what we can learn and how we can implement what we can learn into patient care. And I think there's so many opportunities in this field. And a big part of that is the SRTR and the data that we have, and it is something quite unique. I sit in the Department of Quantitative Health Sciences with a lot of biostatisticians and epidemiologists and so forth that work in other contexts, and I can tell you that it's such a luxury to have all of the data and opportunities for research in our field that many of my colleagues don't a lot to learn from. I actually wear dual hats as well as being an independent researcher in the field. I also spend a lot of time with our quality analytics at our program, interact a lot with clinicians, and see a lot of the day-to-day interactions of how these data are used in practice, some of the perceptions, misconceptions of the data, and we spend a lot of time trying to change the culture so we're more empirically driven. But I think it's also very informative in how these data are interpreted and also how they change practice. And I think there's certainly a big behavioral attribute to a lot of what goes on. So again, I'm giving sort of a research perspective about report cards in general, and I'm going to use the word report cards as synonymous with the program-specific reports that we're talking about here, and starting with not just in the field of transplantation, but more at a high level. So I think it's important to think about what the ultimate purposes of these healthcare report cards are. And to be clear, and speaking from a more academic research perspective, report cards themselves are an intervention. It's a policy, it's an intervention, and should be treated as such, meaning that with an intervention, we expect certain outcomes, and those outcomes should be measurable. So we're measuring the metrics. It's not enough to say we put them out there and hope good things happen, but we have to understand whether the report cards are meeting the intended goals or not, and that's measurable, and that's something that's very impactful, because we do know that report cards can have an effect on the field itself, and when you measure something, it can affect practice. So if we think about at a very high level what the purposes of these report cards are, and we've heard this a lot, one is to inform patient and, in some cases, referring caregivers and having more transparency in healthcare. And perhaps the ultimate aim is that we have information to guide decision making. And going back to what I just alluded to, and we've heard sort of anecdotes about that from our patient representatives and clinicians, I don't think it's very well known in our field how often these report cards, PSRs, are disseminated and utilized by patients, and that's important to understand. If that is an intended goal, we should be able to measure that, understand how it is utilized, much salient to the conversations that we have, and we should understand if there are better ways to disseminate to the broader population. And we're not just talking about recipients, we're not just even talking about candidates, but all the patients who could potentially benefit from this information, and it should be a measurable goal that we, as part and parcel of having these report cards transparently in the public domain. Certainly there's a regulatory oversight piece of this, and we've talked about that, and quality assurance and assuring that healthcare is delivered at a certain level is certainly an important purpose. With that said, I think it's another example where we don't necessarily know the sensitivity and specificity of how we identify high and low performance. We have metrics, whether it's 1 year patient and graft survival, as a proxy for whether a program is performing at a high or low level. But we don't necessarily systematically evaluate whether the programs that we identify or flag, sorry Rich, as underperforming when in the regulatory context necessarily have systematic problems with the delivery of care, or vice versa, if we're missing programs that do in fact have systematic failures in healthcare delivery, and we're not identifying them. So I think, again, this should be part of what we do, that is understand whether the quality assurance piece is effective and we're meeting the goals, and we in fact are identifying programs that could use remediation. Providing incentives and feedback for quality monitoring, and again, this is across many different healthcare contexts, not just SRTR. I would say anecdotally, this is one that there's no doubt. And being in this field as long as I have, over the past decade or two now, we can see the emergence of QAPI in our field has just exponentially increased. And that's probably one of the intended and clear benefits of having these data is we spend a lot more time introspectively at our programs, evaluating our own outcomes, understanding our own outcomes, and though it's an evolution, I think it's something that should be touted as a clear benefit. And identifying best practices and processes of care. And I think this is a little bit nuanced, but has come up in a lot of the discussions about how to change the narrative between identifying programs that are underperforming in the context of quality assurance versus taking all of this data and learning from it, and understanding how the best programs perform, what are the commonalities of those, how we can take that information and leverage it to the broader community and improve patient care. I feel like at our program at the clinic, we spend a lot of time looking at our data. We often find counterintuitive findings, meaning that we might do well in various high-risk groups, not very well in what are traditionally low clinical risk groups and so forth, and understanding what is the commonality between how we're functioning well and how we're not. And that's the context in which this data can be very valuable, but I'm not sure is used uniformly in that way. And the question in the context of this conference is, can the SRTR continue to evolve some of those tools like they've done in the past with the QSUM reports, on which we can take this data not just from a punitive perspective, but really learn best practices and disseminate that more broadly. And the health economists in the room might say that there's also an element of invoking competition, and you want to improve on quality, and sometimes competition can be a mechanism to do that. But on the flip side, there are also concerns about report cards in healthcare. And again, we have to take the lens that this is an intervention. We need to measure whether it's meeting the intended goals, but we also need to be systematic in measuring the unintended potential consequences of this and be responsive to that. We need to be nimble. This is a policy. This is something we check, we recheck, we adapt, and that's how these interventions should be administered. So one of the concerns about report cards in healthcare is creating artificial objectives at the expense of other patient care. So what would be the example in the context of transplantation? Well, traditionally we've focused on day 1 to day 365 post-transplant. That has been the crosshairs of programs. That's what has been built up in the narrative for a long time. And if we put all of our resources to getting to patients to 1 year, does that come in a context of limited resources to the much more, what I would argue, important objectives of long-term survival or getting to a transplant at all, or care administered to the much broader population of those who could benefit from transplantation? And that's something we have to be thoughtful about, and whether there is a trade-off. Use of subjective coding and self-reported data. This is persistent across many domains again, and we're using the same data that individual centers are capturing. There can be an inherent bias for some level of gaming. Variabilities in assessment by statistical approaches. Obviously, SRTR are world experts in statistical assessments of transplant programs, but there's not necessarily always a one-size-fits-all, and there are different ways to do this. And in some contexts, you get different answers depending on the methodological approach. Selective or little use of information by consumers, and I mentioned that on the first slide. We should really understand how these data are used, and obviously one of the main purposes of this conference is whether we can do that better. And then probably the most pernicious unintended consequence, which again is not just relevant to the field of transplantation, but it more broadly has certainly been demonstrated in other areas such as cardiac bypass surgery and others, is the deleterious impact on access to care for quote-unquote vulnerable populations. And particularly salient in the context of transplantation, where in a lot of ways we're selective about what patients we serve, there is this potential, either subconscious or in some cases perhaps conscious bias, not to treat patients that could potentially benefit from transplantation for concerns, either rational or irrational, as Rio described earlier, on access to care for something that might be beneficial. And that's something I think we have to pay very close attention to, understand these practices. We've talked a lot about understanding selection criteria, trying to make these as objective as possible, but it is something we have to be very conscious of in a context in which we know the more transplants we do, the better for public health. It's something that we want to encourage as much transplant activity in general from a population perspective as possible, and any impact which creates any kind of barriers to the growth of transplantation is something we need to take very seriously and understand and measure. There can certainly also be underlying selection bias, and that really means that we know that despite the fact that we have unprecedented capture of the entire census of the population, there are other potential confounders that vary in our very heterogeneous populations across the country, and that is something that can affect the measurement of quality and ultimately some of the unintended consequences. And as described very well by this group and over the past 2 days, often the report cards do not focus on what our patients are most interested in, and being very responsive to that and integrating into practice is also quite important. I just highlighted this quickly because just to make the point that the conversations that we're having around report cards and transplantation are not unique, and this was a systematic review by a researcher named Dana Mukamel, who's very well known in the health services research field, just examining many of these same questions in many other different contexts, including hospitals, nursing homes where report cards are very prolific, health plans, and the X's really represent where there's a lot of empirical research evaluating whether report cards in fact affect consumers' demand and choice. Do they really drive decision making? Are they effective in decision making for the stakeholders, patients that matter? Are there functional responses, meaning that providers engage more in quality? Is there evidence of improvement in outcomes with report cards present or not? But then there's also evidence about dysfunctional responses, and this is, again, salient to transplantation. They use the term cream skimming, which we often equate to cherry picking or thinking more selectively about how patients are treated with a particular intervention, teaching to the test, again, whether we put our emphasis on what is measured at the potential deleterious impact on what is not measured, manipulating data coding practices, and then there's interesting questions about what the financial impact on providers are as well that are relevant, probably less explored in the context of transplantation. So these conversations are real. We know that report cards in healthcare have exponentially increased outside of transplantation, and they're used for a lot of regulatory perspectives, and really important to understand, I think continue to understand in the future. Now, transplantation is not the same as evaluating cardiac bypass surgery or nursing homes or many of the other contexts, and I think it is important to consider what are the potential effect modifiers of transplantation. One is we do have this incredible data resource, and the fact that we have all waitlisted and transplanted patients is very important. Now notice again, that is waitlisted and transplanted patients, and I'll probably mention this more than once in the next 10 minutes or so, that from my perspective, when we measure the impact of report cards, as Dr. Asher alluded to and others have quite eloquently over this time period, I think the relevant conversation for all of these measurements are all patients who could potentially benefit from transplantation. We can't just think about the waitlist population as the denominator. We can't just think about recipients. We really have to think about very intelligently about how these report cards can affect the underlying population, a much broader circle, if you will, of patients that could potentially benefit that are not currently listed and that may be affected by everything that we do. And I think that's something that if we take that lens holistically, I think it's very important and can affect our decision making. If, for example, we find that report cards benefit recipients and waitlisted patients to the detriment of patients not being waitlisted at all, I would argue that's very much a deleterious impact on the broader public health of patients who have end-stage organ disease. And we need to understand that. I'm not saying that's necessarily the case or not, but that's an important lens, I think, to evaluate. We do select our patients, and this is different than evaluating 30-day outcomes for ER visits because we select our patients, and that is something that can be quite heterogeneous by center. We don't necessarily, as I said, we don't capture the underlying population. We've talked a lot about referrals and evaluations and really all the patients who never reach the denominator of transplantation data capture. We do have a limited donor resource. And going back, I've heard the cynical perspective of why do we want to intervene in such a way to increase the waiting list in a context where there are limited donor organs. So if in truth the waiting list shouldn't be 90,000 kidney candidates or the total number, but it should be 200,000 or 300,000 of those who could potentially benefit, what's the point in a context of limited donor organs? It's an interesting thought experiment, given the fact that you could argue that maybe that wouldn't have a net benefit, it wouldn't increase transplants. I would submit that there's a lot of benefits for that. And one of those is just recognizing the problem. The issue of putting the ostrich analogy of putting our head in the sand and ignoring the fact that there are many, many patients that never enter the transplant system is not beneficial. I also think we would be much more innovative and thoughtful about organ selection, more expedited ways in which we can allocate organs if we knew the problem was 2-3-fold more than what it is currently, and we would adapt in ways that are beneficial. And I think for all of those reasons, we should really consider this broader population, think about mechanisms to measure this underlying denominator. And we also have a very unique context, and those of you that haven't been in other areas besides transplant may not appreciate the fact we have what is considered the most efficacious treatment for patients with end organ disease that also happens to be cost effective, particularly in the context of kidney transplantation. So for all those reasons, it's a win-win to do as many as possible, and that should motivate a lot of our activities in terms of promoting access to care and something that has a clear societal benefit from a public health as well as a physical perspective. And we also have great transparency of data and modeling, and that's a credit to the SRTR and everything that is done in the field. Now, when I'm going to mention a couple slides here that challenge that we have made all the strides that we have in the past, and certainly there are things to applaud about our field. But this is a figure which derived from a study that we published, and I think in general has been well known, but really just providing objective data to the fact that the incidence of waitlist placement, and I'll just guide you through this, of patients that are potentially viable for kidney transplantation hasn't changed in 2 decades, more than 2 decades. So of the patients who have end-stage kidney disease that could potentially benefit, we haven't gotten any better over more than 2 decades at placing patients on the waiting list, despite the very well-known benefits of transplantation, the fact that many of these patients would benefit, but yet never reach the system. And the other very pernicious and lasting and prevalent association here is that there's such a strong effect of socioeconomic status, vulnerable populations, disparities in care that hasn't gotten better over this whole time. And I can tell you, many of you have been in this field as long as I have or longer. This is something we talked about 20, 25 years ago and recognized as such a huge societal problem. It hasn't gotten better during this whole time. And that was a key aspect of, or highlighted by the Nason report, and something we need to be very cognizant of when we think about how we can use data to try to improve these processes and measure what is not just good about the field, but also some of the things that we have not improved in our healthcare system. And we do know there are unintended consequences, and I think going back to the fact that report cards have benefits but also potentially unintended consequences is important to recognize and think about strategically about how we might attenuate those. We know that programs that get quote-unquote flagged have a decrease in overall transplant volume, and that probably comes at the cost of patients who could benefit from transplantation. We know that programs tend to reduce utilization of organs that could potentially benefit patients at programs who are identified as underperforming. We know that waitlist removals increase in a dose-response manner if programs are identified as underperforming. And we also know that programs have been identified as underperforming for what many would consider clinically irrelevant differences as 1% and 2% survival post-transplantation compared to the alternative treatment modality. And these are realities, and again, may not always be rational responses to these report cards, but we have to accept that this happens, and we have to be thoughtful about how we can attenuate these effects if we think it's not in patients' best interest. And I think the lens that I like to think about how we can improve our system is we're here focused on task 5 and the SRTR report cards. And there is a reality that patient survival for a candidate, as depicted here in the first plot, is better long-term than a patient who is transplanted at a center that is average, using our old 3-tier system. as well as there's a statistically significant improvement in their patient survival in an average program versus what we used to deem a low-performing transplant program. But this is the survival on the waiting list. And we're spending a lot of time here, and not to say it's not important, and there are not important differences between transplant centers, but what we're spending a lot of focus on is the difference between curves 1, 2, and 3. And if we think about the magnitude of the difference between any of those curves and not getting a transplant at all, that's where we have the most important potential impact for our patient population. And that's where we need to be very thoughtful in how we can get any patients to any of these transplant centers, independent of the fact that there are some variation between centers that we recognize and have talked about. Okay, and I think this is also a field, when we talk about metrics, that it is really ripe for considerations of metrics from a population health perspective. This is a field where we understand there are many handoffs in the delivery of care. There are many metrics which evaluate our pre-transplant providers, such as dialysis facilities, that are not necessarily aligned with what is incentivized for transplant programs or OPOs and so forth. And we really need to think about metrics holistically for this ecosystem in which these providers do not necessarily have the best coordination of care. And there's an opportunity, I think, in a context similar to an accountable care organization, where we understand how do we improve the overall health of patients, regardless if they're listed as late-stage chronic kidney disease, end-stage, a candidate, a recipient, a long-term follow-up. We ultimately want the best outcomes for all these populations despite how they're labeled and across these different providers of care, and I think there's opportunities to do that. So the last thing, this is my last slide, and I'm probably over time, and Sumit's going to kick me, but this is my last point. I would say that the SRTR has been an incredible tool, not just in evaluating our programs and how we can improve, but has been a key resource for understanding the impact of transplantation. And this has been the source by which, for example, we've portrayed the survival benefit of transplantation relative to alternative modalities. This is the resource that we've used. This is so impactful in our field. And I can give many, many, many examples, but just a few. This is something that we've used to approve drugs in our field. These data are the same ones that have been used for empirical evidence to show that there's benefits. These have been used to set guidelines in cardiac care. These data are so valuable in how we understand many different aspects. The idea of donor risk scores, which we use regularly, derive from these data. These data are the endpoints for very multi-million-dollar clinical trials, such as the Apollo study, and so important that these data are accurate and consistently captured in our field. And there are many, many other examples in which these data have been the top impact papers in our field and the ones that drive practice across the board. Now, with that said, there are limitations to the data now, and it may come as a surprise to many of you when we're talking about metrics and we're talking about data. We don't capture currently, because of different challenges in our federal system, some of the most salient outcomes. It may come as a surprise to you that we don't systematically capture graft failures right now for kidney patients. We don't have that information as we had historically. Not because these data don't live and they aren't in the federal system, but there's lack of data sharing between some of our entities. So we can't look at our patients right now and tell what exactly our graft survival rates are at 5 years. And that's troubling. That's a metric which we all have become accustomed to, but we don't capture. And in a very related issue, we don't capture death data for our patients to understand mortality data from our research databases as we had in the past. And that is so impactful for all of the things that I've expressed here and many, many fold beyond that. And I think it's something that, again, these data exist. We know that they are available, and it's very important. And I know the SRTR is well aware of this, HRSA is well aware of this, CMS is well aware of this, but we need to have interventions to make these data whole again so that we can answer the most salient questions in our field and improve patient care. And I just want to emphasize that that is something that is a top priority with the use of these data. So just to conclude, I would say that from a researcher's perspective, we really want to know whether report cards have a net positive or negative effect on patient outcomes. At the end of the day, are these meeting the intended goals or not? More holistic report cards capturing broader timelines are more aligned with patient outcomes, and I think there's been an emphasis on pre-transplant activities, and really should think about all of the different pathways and subway analogy that we've talked about here. The benefits of report cards are not currently systematically measured, and I think it's something we can evolve over time. But unintended consequences are prevalent and important to attenuate and be thoughtful about how we present this information. Transparency of data is absolutely critical to the field, and as I mentioned, these data and metrics are reliant on the most important outcomes for our patients. And pivotal metrics impacting the field from these data are very important for all of our research activities in parallel to the measurement of center quality. So with that, I'll stop. I really appreciate your attention, the opportunity to be here, and look forward to further discussions.
Thank you, Jesse. And on that sobering note, we're going to move on to the next talk by Dr. Layden, who's going to talk about the pros and cons of public versus private metrics. I know we're a little bit behind, but I think we're allowed to keep going. So we'll, instead of breakout sessions at 8:45, we're going to try to see if we can get the breakout sessions at 9.
All right, good morning, everyone. I want to thank the SRTR for the invitation to be here, and to all of you for being so generous and open and candid and engaging the past few days. It's been really inspiring. I am Karen Ledeen. I'm an ethicist and a health services researcher, and have the privilege of chairing the UNOS Ethics Committee. And I'll present to you some data and some arguments from a new white paper that's coming out for public comment, which I think relates to a lot of the discussions that we've had here today. So just a reminder, I think we've heard a lot from different stakeholders about both gaps and opportunities and concerns. And just to remind us, we're all here to learn from each other, to think about strengths and identify gaps, and really to think about how data can be useful and what data is needed. And I think here the point I'd like to underscore, I'm so grateful for Dr. Schultz's presentation on report cards right before this, but I just want to underscore the distinction between report cards and public reporting. So data can be used for metrics to evaluate and compare centers, and it can be used for benchmarking. But we've heard the past few days about the need for data for informational decision-making for patients, for clinicians, for referring physicians. And so, I want to really be clear that having data be public and publicly reported is not just for metrics. It is for metrics also. So what are the goals of public reporting? The goals of public reporting and sharing this comparative information about physicians or hospitals or health plans has been posited to improve healthcare. I think as Dr. Schultz has demonstrated, the evidence is mixed. It does not always do this, and it's often paired with other QI initiatives like pay for performance and other measures. There's two types of public reporting. We've focused a lot on outcomes, but there's also public reporting of processes, which we've heard from patients is very important to them. What is it like to go through the transplant process at Center A versus Center B? And the premise here is that only by making quality information publicly available can it be influential for improving healthcare quality. So how can public reporting improve quality? Well, patients and referring physicians can kind of vote with their feet. They can select centers that best address patient preferences and are aligned and promote patient choices. Centers might respond to public reporting by improving the quality of care if they know that compared to other centers, perhaps they could improve in different areas. Payers may increase access to high quality providers or to providers that are demanded by patients. And reporting may improve trust overall, which is really important to the transplant system in particular, and it may increase accountability. So should we promote public reporting? I think Dr. Schultz gave us a lot to think about in terms of the empirical concerns about whether public reporting is effective and when it is effective, and how we can tailor it to have these metrics best act in the effort of quality improvement without the deleterious effects of potentially exacerbating inequalities. However, I want to present here an ethical framework, which is to say that there may be empirical reasons that we want to improve public reporting or report cards, but there are also ethical frameworks that might compel us to publicly report data above and beyond the empirical evidence for it. And here, just to underscore, is that we can divorce public reporting from punitive consequences, and I think that's something that we've heard repeatedly over the past few days. Public reporting can be used for better decision-making and decision aids and decision tools, for information, for transparency, and to improve trust. And I think in this room, it is very hard to deal and grapple with all of these empirical challenges that were just presented. But this is a transplant community, right? We do hard things every day. I think we can design metrics that can work for the system. So what are the ethical arguments? What's the framework? Why would we otherwise publicly report data? Well, one of the main reasons is to promote autonomy, right? And autonomy refers to one's ability to self-direct, to make a decision that best reflects your preferences or your values, to select a transplant center that is right for you. And without data, without publicly reported data, we've heard repeatedly from the focus groups and from patients that they want this data. They want to be able to select the program or ask about the measures that matter to them in their decision making. And the accessibility and clear presentation of data relevant to shared decision making in particular are critical for patients to exercise their autonomy. A second framework that compels us to publicly report data is a procedural justice framework. And here, this answers the question that we hear often, like, how do we know that all patients are treated like I'm treated? How do I know that I'm being treated fairly? And here, procedural justice upholds a commitment to treating like cases similarly. And for that, we need transparency. We need to know that similar cases are in fact being treated similarly. And this requires that patients have access to the reasons underlying decisions that affect their access to transplant. Including the evaluation process, what they might encounter, what are contraindications, what went into their decision to be waitlisted or not, and to be made inactive or not. This does not require all centers in every program to use the same criteria, and it doesn't require them to offer the same approach, but it does require them to be open and transparent about what that approach is and what were the factors that contributed to their decision-making process. This is really central, just to underscore, for advocacy, right? For the ability for patients to interrogate or appeal or question decisions and act in their own interest. A third principle underscoring public reporting is equity. And here we've heard a lot about, some of the negative consequences that report cards can have for equity, and I think it's very important to take those into account. But it's also important to underscore that equity, insofar as it involves removing structural barriers to accessing transplant and to information, compels us to publicly provide easy, accessible, digestible information that patients can use to make choices about their life and about their care. And here, the asymmetry of information between health, transplant centers or clinicians and patients may worsen outcomes for populations that may have difficulty either accessing information, may have limited health literacy, and indeed may offer new opportunities to question some of the metrics that we've been using, or some of the factors, not metrics, that we've been using in making transplant decisions, such as GFR, which was recently examined, the BMI threshold, which has been discussed many times over the past few days, and psychosocial criteria, which continue to serve as a barrier to some patients in accessing the waitlist. So finally, after considering a range of ethical principles and frameworks, we arrive at utility, which is, I think, what most people have focused on with little consideration to the prior principles. So utility is really the principle here in the context of transplant that refers to the maximization of net benefit, and that may or may not justify transparency. This remains an empirical question, I think, as Dr. Schold has demonstrated. And so here, one thought is that disclosure of relevant information may lead to improvement in utility, as patients may not have to go through the evaluation process multiple times. They may identify more rapidly a program that fits their needs, and that could reduce healthcare expenditures from multiple waitlist evaluations. And that could improve quality, and it could improve outcomes. But it's challenging, and it's unclear whether or not that will occur. So for public reporting to actually improve healthcare, the following needs to happen. The public must know that, well, the public reporting must exist, first of all. We need to identify what are the right measures. These include measures that are relevant to patients. We need to assess them at the right time and to make them accessible, which is no small task, as we've all discussed here. The users must know about the reports, and they must have access to them. They must be able to understand the reports and believe the reports. So some concerns around accuracy, which have been discussed, I think are really important. And users must be able to act on publicly reported data. And as I said, and Dr. Scholl has demonstrated, there's really mixed evidence for this in healthcare, not just in transplant, but in many domains, nursing home selection and cabbages included. So I think we continue to work on that. Additional concerns is that clinicians may avoid patients perceived to be at higher risk, and that ultimately undermines the principles of equity and utility. They may practice defensively in order to avoid being flagged. Nonetheless, as an ethicist, I'll say these empirical challenges should not dissuade us from publicly reporting data. They should encourage us to select and improve the types of monitoring and metrics and benchmarking that we do. Additional concerns that we have heard while drafting this white paper are concerns around misinterpretation and paternalism. So what about patients who don't want to know a lot of information? What about people who do not want to hear this information at a particular time? And I think that in the context of shared decision making, there's a lot of communication that can occur between clinicians and patients around what information is important to you to know, how can I share that with you, and when would you like to hear it? And I think rather than withholding information and using this as a justification for keeping data private, it's better to understand why those concerns arise and to offer educational resources which may help with interpretation. So finally, just to close, I think the ethical analysis is not blind to the empirical challenges, but I think it should motivate us to really think about how we can publicly report data, both pre-listing data, as we've heard, which is so important to patients, evaluation data, data about listing decisions, and outcomes regularly and in a trusted, transparent way. The Ethics Committee for UNOS has established that public reporting can help patients find programs that best fit their needs, their preferences, and their values. And we acknowledge that these empirical challenges remain, including universal adoption and reporting, risk adjustment, which I think is really critical for avoiding some of the deleterious impacts on equity and mitigating disparities. Selecting measures that are important to patients, and using patient-centered design in reporting these measures. So I just want to thank the committee again and all of you for the invitation and for your comments. Thanks.
I guess the SRTR was not kidding when they said the last day would be the hardest in terms of thinking this through, right? So the last talk for this morning before the breakout sessions is another person who needs no introductions, Darren Stewart from UNOS. Darren?
Thanks, Sumit. Thanks for the great talks, Jesse and Karen. Let's see here. So it's exciting to be here. I mean, that's kind of come through evidently from everybody. I was at the 2012 meeting. So here we are a decade later. That meeting was really good. A lot of positive change came from that. The vibe is different here, though, 10 years later, and in a good way. And I really hope that as a community, we look back a year from now, 5 years from now, 10 years from now, as this being kind of a milestone landmark event that led to a lot of positive change to really fill the gaps that are needed in information on transplant for various stakeholders. So I think we're heading there. So on Monday, we covered the who and the why, as you know, and I saw a lot of energy in the room. We heard a lot of energy, a lot of passion for working together to make the system better. that was great, and I think that really provided kindling for and energy and momentum for what happened on Tuesday, which was a big day, where we covered the what. And it's remarkable to me how broad the what is. It's not just metrics, it's information of various sorts. So it's a really broad topic. I'm not going to summarize that here on this one slide in the few minutes that I have. Corey has a printout, I believe, that some of us are going to have with some of the summarization of kind of common themes, common sort of what's that came up in different contexts for different stakeholders. I do want to comment on sort of one of the themes to me that's really come through most evidently, and that is the word upstream. I think a lot of what I've heard can be summarized by the more need for upstream. So first of all, upstream information, whatever that might look like, whether it's metrics, data, or just information about how the system works, what to expect, getting that to patients who are suddenly finding themselves with an organ failure early on, right away, demystifying the process. So getting those touch points more upstream in the process. Upstream also refers to additional collection of data upstream, pre-listing. We've talked a lot about that. Patients who have developed organ failure. What happens to them after that happens? I mean, are they falling through the cracks? Are we missing something with respect to data to be able to capture who is falling through the cracks and how? What interventions might be possible to remedy those disparities and really those missed opportunities. So collecting data upstream on the pre-listing side, but also collecting data and thinking about more upstream measurement on the donor side. We look a lot at actual donors and discard rates and things like that and yield rates, but what about potential donors and where should those data come from? And what about looking at data further upstream from donor hospitals? So really upstream is kind of a key takeaway for me, with one of the main goals too being to eliminate those unknown unknowns. What don't you know that you need to know, and getting that to patients more quickly. So today we're going to be trying to turn those what's into hows, and I'll talk a little bit more about that. And really the purpose of this short presentation is to launch you guys into the next and final set of breakout sessions. So here's kind of how I think about the day 3 charge, and John and Allison and Corey sort of steer me differently if you see it differently, but I think about the charge of today to considering some specifications, some specifics and practicalities. How do we move toward implementing the vision laid out in days 1 and 2? So more specifically, how do we achieve a metrics regime, or really a metrics and information, right? It's not all about metrics, but it's about information, data that are needed at different points along the subway map for different stakeholders at different times to better meet the needs of everybody who's been represented at this meeting. How should we measure the what's, getting more specific? How should we share that information, display that information? And then how should metrics be utilized, and how shouldn't they be utilized, to point out some of Dr. Scholz's kind of comments and concerns as well as Dr. Ledeen. So we've had our amazing subway map to kind of anchor our thinking about all the different touch points where data or information can be helpful for stakeholders, but we've also got our really nice schematic about the Task 5 initiative and the who, why, what, how, and then sort of what comes after that and how it all ties together. So we're at, believe it or not, we're at how, and we're at 4.1, looking at specific metrics. So the way I like to think about this is a funnel context, where day 1, we're thinking about the who, we're thinking about the why, the context. For example, this is just one of the many, many who's and contexts, patients selecting a transplant center. Day 2, narrowing that down to the what. Well, what do you really want to know about a transplant center? Well, one thing I might want to know is how quickly will I be transplanted, based on my blood type, based on my diagnosis, based on this center's practices, or the environment around this transplant center in terms of organ availability. And then today we're narrowing it even further. Well, how do we measure the what? What specific metrics? Is it a transplant rate? Is it a median waiting time? A living donor transplant rate? These are just brainstormed ideas to stimulate your thinking for when you go into your breakout groups. So we want to, I think we want to go into the tall grass a little bit today. We want to go into the rough, if using a golfing analogy, but we want to stay out of the deep weeds. So for example, in talking about specific metrics, we need to talk about what's the numerator, what's the denominator, what are you really measuring, and a little bit of specificity about that denominator. Is it just active patients on the waiting list? Is it all patients on the waiting list? Does it include patients that haven't made it to the waiting list yet? And on the donor side, is it actual donors? Is it potential donors? But I think there's a point where we can go a little too far here today. We don't need to get into what specific cohorts or whether a multi-state competing risk time-varying covariate model needs to be used. That can all come later, statistical methodology and things like that. Should a metric be risk adjusted? Conceptually, that's an important conversation. Usually the answer is yes, but that should be always done thoughtfully. What are the implications of risk adjusting for certain types of things and not other things? We don't need to list out every single patient variable, donor variable today that should be risk adjusted, but that concept about risk adjustment, something that's worth discussing in terms of the how. So thinking about, again, identifying specific metrics, what are the gaps? And again, a lot of that was done yesterday in terms of the what's, but what's not available today but's needed with respect to measuring the system? Is there some excess? Should some metrics go away? Are they no longer useful? Are they redundant given new opportunities, new directions with new data being potentially proposed or coming down the pike? And can there be too many metrics in general such that it's information overload? Is it at some point it's too much or needs to be kind of thought about, so maybe there's a top tier versus a second tier of information for people who want to dig deeper. And I think this is something that it's hard to give this enough attention because we typically in conversations like this, we focus on one sort of measure, one what at a time, and then we move on and talk about another one, and then we talk about another one. But I really think the synergy between metrics, the dependencies between them is really critical to think about as well. And there's so many examples and context in the transplant space where you think about a focus on a post-transplant metric, and the cherry picking, the risk aversion, the selection biases that really a hyper focus on one area can have. Well, what if that's complemented by waiting list metrics that might take some of the pressure off and some of the focus off of that one metric to maybe reduce potentially some of that cherry picking. But then if you have waiting list metrics, are those metrics potentially going to disincentivize listing? So do you maybe need to partner some of these wait list and post-transplant metrics with pre-transplant metrics, rates of acceptance among referrals, and other examples you can think about as well. On the donor side, if you have a donor yield metric, but you don't have a donor conversion metric, is there a disincentive to pursue single organ donors? Things like that, as well as cross-institutional metric synergy. And if you have metrics on an OPO side measuring recovery and transplant of organs, but on the transplant center side, you don't have measures that are incentivizing transplanting more patients, there may be a disconnect and a misalignment of incentives across institutions. So thinking about metrics together is important as well. We're also talking about the method, which consists of data sources, data quality, risk adjustments. So do the data currently exist? These are things that as you go into your breakout groups and think about specific metrics, we want these notes about, is it something that can be done tomorrow, or is it something that needs further planning and additional data collection? If the data exist, are they sufficiently reliable, consistently defined? Are they too often missing? Are there opportunities for improved data quality? Or is it entirely new data that are needed? And is that near-term or long-term feasibility? That's something that the SRTR team, and as we go back, the steering committee can kind of figure out, but good to take a note down for your perspective on the metric you might be proposing. Should metrics be risk adjusted? I covered that as well. There's also always data burden consideration potentially. The use of electronic data transfers, APIs, so to speak, can really help minimize that burden. And so just because there might be an additional burden doesn't mean it should be dismissed as a possibility. And so I think we're also talking about, in terms of the how, the data presentation, as well as a little bit into the result, how the metrics might be used. So the scale chosen can make a difference, right? We've got all these O to E ratios, right? And as a statistician, I kind of think naturally in terms of O to E ratios, but they also leave me wanting at some points. They don't reflect kind of a scale that reflects the real world. They're sort of a theoretical, a relative scale. What if we had a risk-adjusted survival rate difference? So you can see that accounting for patient characteristics, donor characteristics, this center is 96%, whereas this one 94%, putting it on a scale that may be a little bit different than an O to E ratio, something to think about. And maybe that differs for different consumers, and maybe both are good. Similarly, a transplant rate versus a waiting time. What is that median waiting time or average waiting time, despite difficulties sometimes calculating it? Graphical, numerical, how should the data be presented? Should it be presented in 5 stars or bars or tiers? And how should those tiers be calibrated? Should a 3 reflect, average performance, or should a 3, how is a 3 perceived? Those are things that could be revisited in terms of the how as we move forward as a community. Public versus private, Karen nicely covered that. One side note on that is I don't think this is strictly a binary dichotomy. I think there's sort of some middle grounds too. There's been a lot of efforts, collaborative improvement efforts, where groups, consortia of transplant centers, of OPOs are getting together and sharing data, deep dive data with each other to kind of help understand and learn best practices and improve the field together in sort of a quasi public-private data sharing endeavor. And then finally, how should the metrics be used? Does it make sense for them to be performance measures, or maybe not? Many things may not make sense to be a performance measure. It's more informational. Again, Dr. Ledeen covered that concept as well. Informational for stakeholders to make decisions at different points along the subway map. Red lines are a concern, that have been long time concern in the field. Some of that's been changed over the years, where the consequences of being above or below a line are maybe disproportionate to actually what's being measured. And then should mitigating circumstances be accommodated? Something to think about in terms of the how as we move forward with different types of metrics. So we've reached that point where we're going to launch you guys really soon into your next breakout session. So this is old hat for everybody, right? You guys know what you're doing. This is what the worksheet looks like for this third breakout session, the how. And so I think what we want, and again, guys, jump in if you see it a little bit differently. I really think we want a brainstorm list of metrics. What do you call the metric? How do you specify it a little bit without getting too much into the weeds? And then some notes about it. Does it require new data? Does it not make sense to be a performance metric, a regulatory metric, but it does make sense for this purpose? Some of those notes that your group might come up with, and put all that down, and would love to have that rich discussion. And then again, what we're going to be doing is having the one moderator from the groups come back and report out and have a really rich discussion after that. So I think here's where we are with that. A little behind schedule, but we'll be okay. We're going to come back by 10:30. And I believe everybody knows where their breakout groups are, right? And so here's the map of the place that we've gotten to know so well over the last few days. So with that, I will launch you guys into your breakout sessions. Look forward to seeing you back. Yeah.
All right, Darren.
Okay. Good launch, I hope.
I totally forgot. We're also moderating the session after breakout.
Right.